Well, there are already immunotherapy treatments that are the standard of care for patients with advanced hepatocellular carcinoma. And those are the combination of PD-L1 inhibitor atezolizumab with the VEGF inhibitor bevacizumab. And this is approved by the FDA, EMA, and other regulatory agencies. And in addition, we have data recently presented of very similar combination, sintilimab, PD-L1 inhibitor plus bevacizumab biosimilar in a large phase 3 trial run in China in patients with mainly hepatitis B and with very similar results. So this is the standard of care. This is, and now there are other combinations that are being developed under research in phase 3 trials, combinations with tyrosine kinase inhibitors, or combinations of PD-1, PD-L1 inhibitors with CTLA-4 inhibitors, other checkpoint inhibitors. And then after that, there are other strategies like adoptive T cells therapy with cells engineered to recognize specifically tumor cells that are under development in different stages of development. And there are also vaccination strategies that are under development. So we have established therapies and therapies under development. We don't know exactly if what we see with the combination of PD-L1 inhibitors plus VEGF inhibitors is an additive effect or is a synergistic effect. We know that bevacizumab in phase 2 trials has some intrinsic activity, and there are a reduced number of responders. We know that the combination of atezo and bevacizumab is more effective than atezolizumab alone. And there is a good rationale to think that there might be a synergistic effect because VEGF has important roles in the immunosuppressive microenvironment of HCC. And so blocking VEGF could have immunostimulating properties. But we don't know for sure if we are seeing an additive effect of two drugs or a synergistic effect. The currently approved immunotherapy combinations have only shown efficacy in patients in the advanced stage. That means patients with extrahepatic metastases or vascular invasion to the portal vein or hepatic veins, or with a large bulk of disease that makes patients not candidates for intra-arterial therapies. Those are the patients that may benefit from this combination. First is we ignore if the immune checkpoint inhibitor therapies would work in earlier stages, in combination with TACE, in the intermediate stage, in the adjuvant setting after resection or ablation. We ignore that, and we need to know that. Second, there is only a fraction of the patients who respond to these immunotherapies. Basically, these are patients who have ongoing immune responses that are blunted and are not enough effective against the tumor. And because these therapies are expensive, and because we have other therapies that work, there is a absolute need to identify these patients beforehand. There is a need for biomarkers that could help us select the best candidates for immunotherapy. we don't have biomarkers that are good enough to make clinical decisions today. We know that patients with more intratumoral inflammation do better, have more chances of responding and achieving prolonged survival. We know patients that have expression of PD-L1 in the tumor also have increased chances of responding and surviving longer. But these two factors are not ready for clinical use because patients with non-inflamed tumors and patients without PD-L1 expression may respond very well to immunotherapy. So as of today, we cannot say that there are specific patients that respond better. So it's worth treating all patients and identifying early responses so that patients could get the best treatment benefit. This is a truly unmet need. We should not take for granted that because immunotherapies are working in the advanced stage, they should work in earlier stages. But we have the hope that this would be true. There are ongoing trials that have already recruited lots of patients, and I'm sure that in the next 1 to 3 years, we will have a full idea of whether it's worth treating patients in earlier stages. So far, we should refrain from teaching because immunotherapies can also produce toxicities. And in the absence of evidence supporting the use in earlier stages, patients should only be included in clinical trials. I think this is a very relevant scenario because we are seeing that patients in the advanced stage who respond well to therapy have a substantial tumor remission, and sometimes these make unresectable patients resectable. And I do believe that there is room for conversion therapy, so these patients may benefit from subsequent resection or ablation, or even TACE or radioembolization. And what we need is, before we recommend this to everyone, is to run clinical trials with a control arm so that we can make sure that patients that receive these radical therapies do better than patients who do not, because immunotherapies sometimes is so potent that you can achieve long-term complete remissions. So we need clinical trials to answer this question. But this is a very interesting scenario. And Chinese doctors are very experts in resection and ablation and intrathecal therapies, and therefore it's a perfect place for running these trials. The goal of any treatment for a cancer patient, including liver cancer patients, is to prolong survival as much as possible with good quality of life, and if possible, procure a chance for cure. And so we know that in liver cancer, this is usually the result of multidisciplinary management, and patients who can be resected upfront may have a chance of cure. But now with immunotherapies, there is a good chance that we may increase the number of patients that we cure, and certainly we already have increased the number of patients that achieve long-term survival, even in the advanced stage.